Please take your seats. I'm also being very careful not to stand on the extended height adjustment that's in front of me here. So I'm not sure why it's there. But good evening, ladies and gentlemen. My name is Ian Jandrell. I'm a Deputy Vice Chancellor, and it's my absolute privilege to be your host this evening. But my job is very simple. It's to introduce the procession. And of course, I introduce the head of the School of Therapeutic Sciences, Professor Heleen van Aswegen. Welcome. I introduce, of course, our inaugurating professor, Professor Heleen van Aswegen. And the key thing tonight is this is the moment when the new professor professors. And the new professor will do this in front of friends, family, loved ones, and colleagues. It is, in fact, an incredibly important rite of passage in academia. I also do want to extend to everybody just a short apology from the Dean, who is still sitting in Jan Smuts Avenue, because, and I'm looking to the back to my colleagues in ICT, because unlike our campus, the city doesn't have generators to stand by backup on the robot system. So he's really struggling his way here, but he will join us shortly and we'll welcome him when he does that. He'll have a role to play later on in this particular ceremony. Can I also just remind folks that we do anticipate that sometimes, very seldom, but sometimes there is load shedding. We do anticipate that we've got ourselves covered. But what I want everybody to understand, of course, is that the way you react to that, as we know from the previous inaugural lecture, is a means of judging the capacity of the inaugurating professor to deal with these incredibly unknown incidents that do occur. But also, just to let everybody know that one of the irritating things is, whereas the power system will reset very quickly, our ICT systems, of course, need to reboot depending on how they've shut down. So please bear with us. That's the way it is. So finally, a word of welcome to everybody here in the Senate room at the University of Witwatersrand, Johannesburg, and to those of you joining us online. I wish you a really, really great evening. And now it's my privilege to introduce Professor Heleen van Aswegen, or to invite Professor Heleen van Aswegen to introduce our inaugurating professor. Heleen.
I think I will also avoid the accommodations that have been made back here, lest I go out of camera picture. So I just want to say, you know, the Dean would ordinarily have been doing the introduction. He's arrived. I think I should allow you to come to the podium. So you need to catch your breath. You're going to have to pay me double for this. Now I can't actually do my joke because he's sitting in the room. So I do know, I was going to say, Professor Madi, that just imagine that I'm a very handsome, tall, A-rated Indian man, and I am going to do the job of my dean. But going forward, I have the pleasure to do two things this evening now. And that is to introduce Heleen van Aswegen, who is a personal professor in the Department of Physiotherapy in the Faculty of Health Sciences. She teaches cardiopulmonary physiotherapy at undergraduate and postgraduate levels and has supervised 28 postgraduate students, both at MSc and PhD level, to completion successfully, by the way, of their degrees. Her research interest is physiotherapy in the fields of critical care and trauma. She has published 65 articles in peer-reviewed journals and 10 book chapters. Heleen edited a textbook titled Cardiopulmonary Physiotherapy in Trauma, an evidence-based approach, published in 2015. She has been an invited speaker at numerous physiotherapy, critical care, and trauma congresses, and has research collaborations with colleagues in Sweden, New Zealand, and Australia. I would like to invite Professor van Aswegen to the podium to deliver her inaugural address. Thank you.
Thank you very much, Professor Meeswa, for the introduction. And thank you, Professor Mahdi and Professor Jandal, for being here. And also thank you to Prof. Meeswa in advance for doing the vote of thanks after my presentation. I would like to welcome my husband, Chris, my family, which includes my mom and dad and my sister who drove up from Bloemfontein this morning to be here in person. And also I'd like to welcome my brother and sister-in-law who are online and listening from Austin, Texas. So hi to you guys. I would like to thank everybody that's come to attend this session this afternoon in person. They include colleagues, friends, postgraduate students, and also I want to acknowledge everybody that is attending online. And I want to thank you so much for all the beautiful messages of congratulations that I've received from everyone. I think that includes, that concludes the thanks, except to also say thank you so much to Kelebogile Tladi from the BITS Functions and Events Department, who did such an amazing job to market this event and to organize everything for this afternoon. And then also thank you to David Tarke from BITS ICT and Bumzile from the Audiovisual Division for assisting me this afternoon to make sure that everything runs smoothly. And then I'd like to also thank Mr. Marlon Lekey from the BITS Physiotherapy Department for helping me to make some of my slides look pretty. Okay, I just want to share quickly. Okay, there we go. So my love for everything intensive care didn't start when I joined Wits University in the early 2000s. It had its roots in Bloemfontein, where I grew up as one of 3 siblings. And as you can see from the picture, I grew up in a household where mom and dad were both university graduates, and both of them also worked at the University of the Free State. My dad as a professor in nuclear medicine, and my mom as a lecturer in communication science. And I've got very vivid memories of seeing them preparing in the evenings for lectures that they were doing the following day, and also marking student assignments and exam papers. And little did I know that I would follow firmly in their footsteps several years later. I did my undergraduate studies at the University of the Free State. And after I graduated, my first job was at Pelenomi Hospital, where my very first clinical rotation was in the multidisciplinary intensive care unit. I had the privilege to work with Professor Ben de Vol, who was an intensivist and very passionate about patient care in the ICU setting, but also about interprofessional collaboration in managing patients in the units. And I remember very well how he always included me in his ward rounds and asked my opinions from a physiotherapy point of view about patient care. And that is where the seed was planted for my love for intensive care. During that time, in the early 1990s, I was always very keen when I received the Physiotherapy Journal to see if there are any articles published about cardiopulmonary physiotherapy. And every now and again, there would be an article published like this one by Professor Celie Eels, who at the time worked at the Wits Physiotherapy Department. And these articles were such an inspiration to me. And that, together with my clinical experience at Pelenomi Hospital, encouraged me to enroll for an MSc at the University of the Free State. After successful completion of my MSc, I decided to spread my wings and fly to the United Kingdom for a different experience. And I had the privilege to work in several NHS hospitals with very knowledgeable and experienced physiotherapists in the acute medical wards, the surgical wards, and the rheumatology wards. And particularly the time that I was the ICU lead for the physiotherapy team at Charing Cross Hospital was very instrumental in creating the pathway into physiotherapy and intensive care. During that time, I made my first contribution to the cardiopulmonary physiotherapy research arena by publishing the results of my master's degree. And towards the end of 2001, I longed to return to South Africa, but by then I'd had about 10 years of clinical experience and I was looking for a new challenge. During the last few months of 2001, a position as cardiopulmonary physiotherapy lecturer became available here at Wits University. And Professor Amy Stewart, who is sitting in the audience, and Professor Celie Eels, who I admired from the 1990s, interviewed me for the job. And I was very fortunate to get the position, and I've been at Wits ever since. So last year I celebrated my 20-year anniversary at Wits University, and that is where my research career really took off. So I'm grateful for the privilege this afternoon to share with you the research work that I've done with academic colleagues and postgraduate students in the field of intensive care and trauma care. So let's look at illuminating the practice of physiotherapy in South Africa. Now, worldwide, there is sufficient evidence to show that physiotherapists are widely recognized as integral members of the multidisciplinary team that provide care and rehabilitation for patients in intensive care units. In the early 2000s, very little had been published about the role of physiotherapy in intensive care. And one of the first publications that I made in my time at Wits was with my colleague Joanne Potterton, where we conducted a survey throughout South Africa to be able to describe what physiotherapists do in the intensive care unit. This survey defined all the respiratory physiotherapy techniques that physios commonly used. It also describes the rehabilitation in reference to exercise therapy and mobilization of patients out of bed. And we found that around 96% of the physiotherapists provided an after-hours and weekend service delivery to patients in the ICU. We looked at whether there was a difference in practice between those working in public health care ICUs and private ICUs, and the scope of practice seemed to be very similar. We also compared these findings with a survey that was published for European physiotherapists a few years earlier, and the South African scope of practice reflected quite well from, compared to the European survey. So this was published in 2005. About 10 years later, we repeated the survey to see whether scope of practice had changed over time and to see whether it was still evidence-based. And thankfully, we found that physiotherapy scope of practice was still evidence-based. We were still providing care to patients after hours and over weekends as well. But the one thing that we found was that physiotherapists working in ICU did not regularly use outcome measures to assess patients' response to treatment and to guide their approach to patient management. Now, in recognition of this work that we've done, I was invited by Professor Susan Hanekom from Stellenbosch University to be part of this collaborative project where we developed minimum clinical standards for physiotherapy in South African ICUs. We interviewed around 50 to 60 physiotherapists in focus group sessions, which we held in Johannesburg, Durban, and Cape Town. And the conclusion was that physiotherapists should be able to have an integral medical knowledge, including knowledge about anatomy, physiology, pathophysiology, the ICU environment particularly, and pharmacology, to be able to work safely and effectively with patients in this setting. Also, physiotherapists need to have the skill to work well in a multidisciplinary team with regards to professionalism, the ability to communicate clearly, and ethical practice. And also that physiotherapy practice should be evidence-based, that physiotherapists should be skilled in applying the techniques that are particular to ICU inpatient management, and that we should have good handling skills. So this article contributed new knowledge to the field and was published in 2017 and cited by several researchers from Africa, but also from Europe. So, having defined the scope of practice of physiotherapy in the ICU, particularly for the South African context, and developing minimum clinical guidelines, we now look at patient care in the ICU in relation to the ABCDEFG bundle of care. And this is a care bundle adopted worldwide by intensivists and their teams who look after patients who are critically ill. So A, referring to airway management and assessment and management of pain. B, referring to interruption of mechanical ventilation and spontaneous breathing trials in order to try and liberate the patient from mechanical ventilation as soon as possible. C refers to choice of analgesia and sedation and coordination of care. D to delirium management. E to early mobilization and exercise. F to family involvement, follow-up referrals and functional reconciliation. G to good communication and good sleep. And lastly, H that refers to handout materials and education of patients, specifically with regards to complications that they may develop due to critical illness, including ICU-acquired weakness and post-intensive care syndrome. So now I'll share with you how the research that we have done over the last few years have contributed to some of these aspects of patient care in the ICU. So looking at spontaneous breathing, many patients who are critically ill are admitted into the unit with respiratory failure, and that means that they will be intubated and mechanically ventilated from the outset. And the aim is to try and get them to wake up and be able to breathe as quickly as possible on their own again, so that we can reduce their length of stay in the ICU and therefore reduce the number of complications that they may develop. So in order for patients to breathe effectively with less mechanical ventilation support, there should be no resistance to airflow through the lungs. Resistance to airflow through the lungs develops when the airway walls are inflamed due to infection or inflammation. If there is a contraction of the smooth muscles around the airway walls, which reduces the internal diameter of the airways, and if there is excessive secretions in the airways that reduce the internal diameter. So one of the strategies that physiotherapists and nurses use in intensive care to reduce resistance to airflow and to help reduce swelling in the airway walls is administration of medication by using a nebulizer device, which we attach into the mechanical ventilation circuit. So one of my MSc students came with a question whether there is contamination that occurs over time within these nebulizer devices, and whether intensive care units have got decontamination protocols in place to guide the management of these devices in cleaning them. So in collaboration with Professor Sandy van Vieren from the Wits Pharmacy Department, we conducted this study, And we had 14 intensive care units that participated. We swabbed nebulizers that we saw were used within a mechanical ventilation circuit and swabbed over a blood agar plate, which was then cultured in the laboratory to see whether colony-forming units were cultured or not. What we found is that the majority of the nebulizers used within the mechanical ventilation circuits in these ICUs in Johannesburg had bacterial growth, and that the nebulizers who were contaminated and who were stored by the patient's bedside under a sterile drape on top of the ventilator, which is a dark, warm environment, had the most contamination. And at the time, that was the most common practice in those units as well. And then also we found that none of the participating ICUs had a nebulizer decontamination protocol in place, which was a bit concerning. A few years later, again in collaboration with Professor van Vieren, we repeated this study in Pretoria, where we had several participating ICUs, and we then included the vibrating mesh nebulizer, which you see on the left top of the slide, which can also be attached into a mechanical ventilator circuit. These nebulizers are kept in place in the circuit. They are not opened and closed by removing them from the circuit. So we wanted to compare whether there was a difference in contamination between these two types of nebulizers. And we also took samples of air from around the patient's bedside to test for contamination. Again, we found that more than 50% of the nebulizers and most of the air samples were contaminated. In this case, most of the ICUs had a nebulizer decontamination protocol in place, but with observation of practice within the units, it was clear that that protocol was not always followed. With this study, we highlighted that nebulizers with the least contamination were nebulizers that were rinsed under running water and then wiped dry with an alcohol wipe and left open to the atmosphere to dry. And we cultured within these nebulizers Staphylococcus species and Enterococcus species, which are common causes of ventilator-associated pneumonia. So the take-home message from this study was that the staff in the unit who use nebulizers and inject medication into the vibrating mesh nebulizers or use jet nebulizers that we need to open and close the ventilator circuit for need to be more consistent with hand washing as they handle the nebulizers, and also to wear gloves if possible. And then to encourage staff to be more adherent to the nebulizer decontamination protocols, particularly physiotherapists, because we don't always ask when we work in a unit whether there is a particular protocol for the management of these devices. Another method of reducing the resistance to airflow through the airways is by using a manual hyperinflation bag as part of our physiotherapy treatment of patients' chests. This is to encourage the movement of secretions from the more distal parts of the airways more centrally towards the trachea so that it can be suctioned out, particularly for patients who are more sedated and less cooperative with other methods of physiotherapy to clear the secretions from their lungs. So the picture that you see on the left bottom is the type of ambu bag that is frequently used in public health care and private sector ICUs in South Africa. And the other picture is the type of ambu bag that was used very frequently in the United Kingdom. So I wanted to answer the question of whether there was a difference in distribution of airflow through the lungs between these two circuits, and how do these two circuits impact on patients' dynamic lung compliance. So in collaboration with my dad at the Free State University and also the Critical Care Division at the Free State University, we conducted this study. And this was a crossover randomized trial where each patient was treated with both circuits on different days and acted as their own controls. We took these patients from intensive care down to the nuclear physics department. We administered technetium gas, which is a radioactive gas that then shows the distribution of air through the lungs while you ambibag by taking pictures with a gamma camera. And the patients were positioned in supine, so lying on their back during the procedure. As you can see from the results, there was no significant difference in effectiveness of airflow distribution through the patient's lungs between the two circuits. So the two circuits worked equally well. A very interesting finding was that in the supine position, the least amount of airflow distribution was detected in the left lower lobes of the lungs. And this led us to the conclusion that if one has a patient in the intensive care unit that is mechanically ventilated with pathology in the left lower lobes, it is best to treat them in a right side lying position and not in supine, so that in the right side lying position, the left lung is uppermost and airflow can be more preferentially distributed to the left lower lobes. Physiotherapists spend about 30 to 45 minutes at a time with a patient in the ICU, delivering chest physiotherapy treatment, but also rehabilitation and exercise therapy. So physiotherapists, together with nurses who work in the ICU, are well positioned to advise the medical team regarding the patient's appropriateness for weaning from ventilation and also readiness for extubation so that they can breathe on their own. So traditionally in intensive care units throughout South Africa, the doctor is the person that makes the decision as to whether the patient can be weaned from mechanical ventilation and when the patient is ready to be extubated. Natasha Plani, who was an experienced physiotherapist at the time, came to me with the research question if she developed within the unit that she worked a weaning and extubation protocol, which was a checklist with parameters that the patient had to meet to show that they're ready for ventilation and to show that they're ready for extubation. And this weaning protocol is used by the nurses and the physios in the units. Would it make any difference to the patient's mechanical ventilation time and length of stay in the ICU? So we did this experimental study where we had a group of patients that we then managed according to the nursing and physiotherapy weaning and extubation protocol. And we compared their outcomes to a historical group that had been managed according to physician preference. And we found that the patients managed according to the nurses and physiotherapist weaning protocol had a clinically significant shorter mechanical ventilation time, but we were not able to show a reduction in length of stay in the ICU because the doctors would only agree to the nurses and physiotherapy weaning protocol if they were the ones that then had the final say of when a patient was transferred to the ward. So we were glad to show that when you have experienced physiotherapists that work together with the nurses, it can make a difference in mechanical ventilation time and therefore reduce the risk for patients in developing respiratory complications. So that was an encouraging finding. And then leading on from that work, we wanted to get an idea of where physiotherapists were positioned across the country when it came to their involvement in weaning and extubating patients in the units that they worked in. Unfortunately, the results were a little bit disappointing. Of the people that participated in this survey, only 4% were routinely involved in decision-making with the ICU team to wean and extubate patients. A third, 30% were routinely performing extubation at that time, which means removal of the artificial airway from the patient's lungs. And this is within the scope of practice of physiotherapy in South Africa. Majority of them reported that they used early mobilization activities, exercise therapy, and deep breathing exercises as forms of respiratory muscle training in order to prepare patients for weaning and extubation, and that was reflective of the research evidence at the time. But physiotherapists were less involved in developing weaning and extubation protocols for the units that they worked in. A possible explanation for these less encouraging results was that most of the participants were junior physiotherapists from public healthcare sector hospitals, where there was not always a senior physiotherapist available to guide care in the unit. And because these physios were less experienced, they were less involved in these decision-making processes. If you can remember from the ABCDEFG bundle of care that I presented earlier, E stood for early mobilization and exercise therapy, which is worldwide, recognized worldwide nowadays as a very important component of patient care. In 2011, I was invited by Professor Susan Hanekom again from Stellenbosch University to be part of a group that developed clinical management algorithms for early physical activity and mobilization of critically ill patients. Within this paper, we described the parameters that need to be assessed in order to make decisions regarding the type of physical activity performed with patients who are less able to cooperate, those that have a shorter length of stay and those that have a longer length of stay. So to guide that process of early physical activity and in and out of bed mobilization. And this paper also describes safety criteria to check to see whether the patient is responding appropriately to the therapy that we're giving them. So this paper has been recognized worldwide, cited by a large number of researchers as they continue to do research on early mobilization in their units. Following on from that publication, in the last few years, one of my PhD students, Catherine Tatianemandu, wanted to investigate the use of early mobilization in Southern African intensive care units. So we performed a cross-sectional study in Zimbabwe in participating public healthcare sector ICUs and also in South Africa. What we found is that only about 20% of patients had been mobilized out of bed at the time of the survey, and many reasons for why patients were not mobilized out of bed included patient unresponsiveness, a lack of staff in the unit, and for any of you who have been in an intensive care unit, patients have lots of attachments to them. So it is an impossible task for one person to mobilize a patient out of bed in ICU. So lack of staff and lack of rehabilitation equipment, availability of that in the ICUs were raised as reasons for low out of bed mobilization. And this may suggest that we have not fully adopted the ABCDEFG bundle of care for patients in the Southern African regions in all participating hospitals. So as part of this PhD project, we also wanted to highlight barriers and facilitators to implementation of early mobilization in ICUs, where we interviewed 22 physiotherapists. And the important findings here was that if professional roles and boundaries were not defined regarding patient care and who is responsible for taking the patient out of bed and who is responsible for putting them back into bed, it poses a big barrier in having early mobilization of patients as a continuous service delivery in the unit. The structure of physiotherapy service provision to many intensive care units in the public healthcare sector in South Africa and Zimbabwe includes physiotherapists not just working in the ICU, but on a daily basis also having to cover patients in other wards in the hospital. And this results in inconsistent presence of the physiotherapist in the ICU. And this was highlighted by participants as another barrier to instituting early mobilization and having it as a continuous service. Good communication between team members to establish when a patient is ready for mobilization out of bed was also highlighted as an important factor that influences early mobilization of these patients. In this study by Namusa and Tinka, we looked at physiotherapist perceptions of collaborations with the interprofessional team members in the ICUs that they were working in. So we conducted interviews with these physiotherapists, and the main themes that came forth from this research showed that barriers to interprofessional relationships in the ICU included personality types that cause friction between team members, non-ICU trained staff that don't always understand the role of the physiotherapist and disappear when the physiotherapist arrives to treat the patient in the unit. And as I've mentioned before, it's very difficult to do rehabilitation with a patient when you're on your own, especially if there's no nurses to assist you at the time. Lack of professional etiquette and frequent rotation of staff were other barriers mentioned. Enablers of collaboration between team members included the presence of team members in the unit, optimal time management and a teamwork approach to patient care, and importantly, sharing of knowledge between the different professions in the unit. So the differing paradigms of teamwork among healthcare professionals was highlighted as a cause of tension within the interprofessional collaborations in the unit. So with all this research that we'd done in the field of critical care, I've often wondered, what about patients with traumatic injury? Because over the years that I've been involved with clinical work and research, one of the main reasons for patients to be admitted into ICUs in South Africa is traumatic injury because of our high incidence of motor vehicle accidents and interpersonal assault. So very little was published about this, and particularly the ICU management of patients with traumatic injury, apart from the few articles published by Celie Eels in 1990. So in order to bridge this gap in available evidence for physiotherapists to guide them with the management of these patients, I approached Professor Brenda Morrow from UCT, who is a pediatric physiotherapist, and we pulled together a team of South African physiotherapy clinicians who were experts in trauma care, and also South African academics who were experts in trauma care. And we wrote a book, which you've already heard of, the Cardiopulmonary Physiotherapy in Trauma textbook, which was published in 2015. And we were 8 people that wrote this book. This book was very well received in the physiotherapy community, not just in South Africa, but worldwide. It became a prescribed text, and several physiotherapy departments at hospitals throughout the country purchased copies of this book. I also received several requests from international physiotherapists for copies of chapters in this book. So we were very grateful that the book was so well received. We've just recently completed the updates for the 2nd edition of the book, which will be published in towards the end of this year or early 2024. And what makes us excited about this book is that we added 2 new chapters to the book, and we had the initial writers from 2015 again as collaborators, but we invited physiotherapists from the United Kingdom, from Australia, and from Sweden to help us write. And we also have 2 trauma surgeons, nurses, occupational therapists, and pain experts that collaborated with this version of the textbook. So we are quite proud of this. So thank you. So further work that we've done in the field of trauma is to look at particularly the physiotherapy management of patients admitted into the hospital due to major chest trauma. And I drew together this collaborative team of researchers from Australia, Sweden, New Zealand, and UCT. And we conducted a global survey to find out what do physios across the world use in their management of these patients. So we summarized findings that reported on use of active coughing, body positioning, deep breathing exercises, and early mobilization. But we did find that practice differed between countries, and also that after hospital discharge and continued rehabilitation was very seldomly done by anybody across the world. So for this reason, we have continued collaborations with Sweden. Professor Monica Fagerbeck-Olsen is working together with me, where we are investigating more closely the difference in practice between patients with major chest trauma between our 2 countries, and where we plan to implement interventions and see how that impacts on patient outcomes. I was invited to write a state-of-the-art review on the physiotherapy management of patients with trunk trauma by Professor Amy Stewart, who's here in the audience and is the editor of the South African Journal of Physiotherapy. And this review basically summarized all the treatment techniques that we have evidence for to use in patients who suffer trunk trauma within an acute care setting. We did find that many of the studies were of low to moderate quality, and even though there was some research available on the physio management of patients with chest trauma, there's very little written up about physiotherapy management of patients with traumatic abdominal injuries. So this is a field that we are starting to explore now from the physiotherapy department. Other work in trauma care that we've done was to investigate the effectiveness of non-pharmacological therapeutic interventions on level of pain experienced and level of physical function in adults with rib fractures in an acute care setting. And our systematic review and meta-analysis showed that one could use deep breathing exercises, transcutaneous electrical nerve stimulation, and that physiotherapy as part of a multidisciplinary team care bundle is very important in improving outcomes for these patients. If you can recall at the beginning of my presentation, I mentioned that physiotherapists don't always use objective outcome measures to assess the response of their patients to treatment on a regular basis. So we used the Chelsea Critical Care Physical Assessment tool, and we wanted to see how adding that tool as an outcome measure to assess patient response to standard care influenced patients' level of function at time of discharge from ICU and their length of stay. So we did this study at one of the public sector hospitals in Johannesburg, and we found that the CPACS tool helped physiotherapists to individualize the treatment approach to their patients in the unit more effectively, and that patients achieved a higher level of physical function at discharge from the ICU And the physios that participated in the study also reported that it didn't take as long as they expected to fill out this questionnaire, and that it was actually fairly easy to implement it into daily clinical practice. We've just finished writing an article where we looked at the CPACS tool and compared it to another physical function assessment tool used in ICU settings across the world called the PFIT. And we tested this in patients who had elective abdominal surgery. So currently the paper is under review, and hopefully it will be published in the next few months. So contributing a little bit more to the field of outcome measure use in ICU. So with having done all this research on defining physiotherapy practice in ICU and highlighting some of the treatment interventions used in the ICU, we wanted to explore patient outcomes after discharge from the ICU over a 6-month period as they recover from surgery or the injuries that they sustained. So one of the serious complications of critical illness is post-intensive care syndrome. And this is defined as physical, mental, emotional, and cognitive symptoms that persist after discharge from hospital and impact patient recovery for months or years afterwards. And patients who are at risk of developing post-intensive care syndrome are those that are more severely ill on admission to ICU, and also those who developed complications during their stay in the ICU, such as sepsis. Patients who needed treatment with surveillance equipment like mechanical ventilation or renal dialysis are also at greater risk, and also those with prior cognitive impairments, and most medications administered to patients over a prolonged period of time have been linked with the development of PICS. So a few years ago, in 2010, I did my PhD and had Professor Seeley Ills as my PhD mentor. And we looked at the impact of penetrating trunk trauma and mechanical ventilation on the recovery of survivors after hospital discharge. In these 2 papers that are highlighted on the slide, we reported on the patient's ability to perform physical exercise, their pulmonary function, their muscle strength, as well as their quality of life. Moving on from this work, we investigated health-related quality of life of survivors of a mixed trauma cohort, so chest trauma, but also multiple orthopedic injuries. And we also did a 3rd study looking at biopsychosocial outcomes for a mixed cohort of medical and surgical patients managed in the unit. So the results of all 3 of these studies are listed on the slide here. And as you can see, the participants for all 3 of these trials were of working age. And the participants had a prolonged hospital length of stay, which caused all of them at 6 months after discharge to still have below normal or below expected exercise capacity. Majority still reported feelings of discomfort and pain at 6 months after discharge. Some had persistent muscle weakness, low quality of life related to physical function and mental health, and that factors that were associated with these outcomes included morbidity, so severity of illness while they were in the ICU, that impacted on their outcomes 6 months after discharge, and also duration of mechanical ventilation and length of stay in the hospital. So all 3 of these studies have a little asterisk next to them, and that is to show that during this time, our participants already exhibited symptoms of post-intensive care syndrome. We just didn't have a name to give it at the time. So therefore, it is important that we continue to do research on the effectiveness of rehabilitation services provided to patients after discharge from the hospital. All the clinicians in the room here can attest to the fact that physiotherapists see these patients and treat them. We are just very behind in developing the research to support the physiotherapy intervention for these patients from an evidence-based point of view. Then lastly, I just want to share with you a very small case report that we did to report on the impact of physiotherapy on two survivors of COVID, and more to report on how these patients responded to physiotherapy that was initiated in the hospital and then followed through after discharge from the hospital. So treatment given to the patients in the hospital was gradually progressed as the patients responded well to the interventions. And for both of these patients, they had lung function that reflected what we would expect them to have by 6 months after discharge. Their exercise capacity had increased significantly, and both of them had returned to work by 6 months after discharge. So it's a small study, but it's starting to document the effects of physiotherapy provided to these survivors of severe illness after discharge from the hospital. And we've just concluded another study that looked at physiotherapy intervention for survivors of chest trauma, also given to them over the first 6 months after discharge. So we hope to report on that in the next 6 months. So what's next? And I think what's next is for us to continue to build on the foundation of evidence that we've provided, particularly regarding physiotherapy in the South African context. So there's still a lot of work to be done, but thankfully I've still got another 12 years at it. So, of course, all these achievements would not be possible if it was not for the support and encouragement of others. So I would like to acknowledge the heads of department that I've worked with since I've joined Wits University. And I've got Heleen van Aswegen here as a previous HOD, Prof. Amy Stewart as an acting HOD before Helen. And then our current HOD, Veronica Ntia, who is also here. And just a word of thanks to you for allowing me the time to be away from the office or away from teaching, to write, to present at congresses, and for your support for funding applications. I want to also thank my research role models that started with my mom and dad, who did research while we were still children. And then carry through my thanks to Professor Seeley Eels, who really embedded a love for research within me. And of course, everything that I learned from Amy and also from Helen and other colleagues in the department. My colleagues, thank you for your continued support of my efforts, and also for being more than just colleagues, but also friends. And then particularly Professor Ronald, who I've had the privilege to work with for the last 15 years, I think. We both teach cardiopulmonary physiotherapy. And Ronald, I've always enjoyed learning with you and learning from you, and really hope that we will continue to publish together in the next few years until one of us retires. Then I want to thank all the research collaborators that I've worked with over the years. On the top row, we've got the international collaborators, Professor Shane Patman from Notre Dame University, Kerry Battle from Swansea in Wales, Professor Monica Olsen from Gothenburg University, who is now appointed as a visiting professor in our department, Julie Reeve from Auckland University of Technology, and Lisa Beach from the Royal Melbourne Hospital. Then also thanks to Romy Parker and Brenda Morrow from the University of Cape Town, to my dad from the University of the Free State, and also the other colleagues in the critical care division there, Professor Susan Hanekom from Stellenbosch University, and Professor Sandy van Vieren from the Wits Pharmacy Division. And then a great word of thanks to the hospitals within Johannesburg that have supported our research efforts over the years. This includes Baragwanath, Physiotherapy Department, and Elisma, the head of department, is here tonight. Also thanks to the Netcare hospitals, particularly through the practice of Natasha Plani and Moira Wilson at Mill Park Hospital, and then also to the physiotherapists at Charlotte Matseke Johannesburg Academic Hospital. Thank you so much. I'm not done yet. Sorry. Then thank you so much to all the postgraduate students that have walked their journey under my supervision. And many of you are here tonight, which I really appreciate from the bottom of my heart. With some of you, we've walked the MSc journey, others we've had a PhD journey, and others we've had an MSc and a PhD journey, and it's always been a pleasure. And I would not be standing here as a full professor if it wasn't for all your hard work and effort. So you did not just gain a degree from Wits University, but you helped to build my research profile as well. So thank you so much. And then the research is not possible without the money to fund the research. So a word of thanks to the National Research Foundation, the South African Society of Physiotherapy Research Foundation, and Wits University for allowing me to use my research funds, and for also sponsoring through various committees some of the research that was done. And then on a more personal level, I would like to thank my husband, Chris Evans, for his undying support of my career. There's the quote that you all know that says, behind a successful man is a woman. Well, next to this woman is a wonderful Mr. Evans that always supports my responsibilities at Wits and never complains when I need to work, and always is happy to jump in and help with household chores. So, Lovey, thank you so much. And then lastly, to my family, it is such a privilege to have you here tonight to share this wonderful experience with you. Thank you for your love and support, and for being my best cheerleaders and always celebrating with me every achievement that I've had so far. Thank you very much for listening.
Thank you and good evening. So, Prof. van Aswegen, thanks for that really eloquent talk. And I think it really epitomizes the type of research which takes place at Wits. And especially the importance of it being context specific and how it eventually ends up being able to influence the lives of people. Personally, it resonates with me. I spent 10 years as an intensivist at Chris Hani Baragwanath Hospital and can fully appreciate the important role that physiotherapists play. Both when really stuck in terms of not being able to get the patient off the ventilator, we say call a physiotherapist, they'll sort it out. But more important is to actually get a patient out of the bed. And as you also illustrated, the importance of actually understanding what are the sequelae of ICU admissions. And certainly the breadth of work that you've been able to share with us, so that you pretty much have then really checked all of those boxes, and certainly deserving of the recognition as a present professor at Wits University. That being said, I'm also delighted. Perhaps the most important part of your talk was actually indicating that you intend to remain at Wits for the next 12 years. And certainly the choice of coming to Wits in the first place, rather than going back to your alma mater, UFC, was a good choice. So well done with that too. So at this stage, I really like to again, congratulations on the promotion, and I would like to call upon Prof. Heleen van Aswegen, who has already been introduced to you, who is Professor and Head of School of Therapeutic Sciences in the Faculty of Health Sciences. She has held several leadership positions in both clinical practice as well as in academic setting. Helen's expertise is and research expertise is in the field of HIV and disability in adults, and she has conducted amongst the first studies to define the extent of HIV disability in an African setting. She has also been involved in research in terms of understanding the scope and impact of disability in people living with HIV, and again, conducted among the first of population-based studies in this respect. The other of interest in terms of research relates to study of service delivery systems and research in involving service delivery management models, the structure and monitoring and evaluation system. Helen and Heleen have worked as colleagues in a physiotherapy department for several years. They've published together and co-supervised PhD students. Prof. Aswegen has known Heleen and her work and is therefore well placed to deliver a final vote of thanks. Helen.
I'm back again. Thank you very much for asking me to do this vote of thanks, Heleen. And it really is a pleasure on my part and an honor. I just want to say you gave a long line of thanks to many people, but you forgot two people, or two. I won't say people. Piccolino, who is Helene's cat, who unfortunately passed a few weeks ago. And the reason why I mention it, apart from speaking about ICU care, but when Helene would tell me stories about Piccolino, the light in her eyes was just fascinating. And the second one was her nephew, Christian, whom she said, sorry, Chris, was her husband at the time. So I'm sure that in your heart, you're thinking they added to your balance in life. But let me get to what I'm supposed to do today. And I want to say that Heleen van Aswegen, Professor Heleen van Aswegen, is the first physiotherapist I met who took great pleasure in describing the colorful nature of cardiopulmonary and respiratory and chest physiotherapy. Everyone comes out of university with one pet subject that they would rather forget. For me, it was cardiorespiratory. Having trained in the UK, where for many days you would do chest physiotherapy on the old folk, and they had very colorful products. So when I came to WITS, I asked about the different areas of specialization that WITS had, and they said cardiorespiratory, and I thought, yo, somebody's got an interest in that. I've got to meet this person. They must be special. So I went off and met Heleen, and she started chatting about cardiorespiratory. Well, let me tell you, by the time I left there, I thought, wow, there must be something to this. And over the years, I was in awe of the depth of science, and I just thought it was secretions at the time that I was a student. But I was in awe of the depth of science and you know, the level at which the knowledge had developed, because by the time I came to WITS, I had been working for 20 years in public health. I realized the fascinating world of chest physio, respiratory care, and in particular intensive care beyond my undergraduate training, where I had only memorized the fundamentals of blood gases, acid-base balance to make sure that I passed that section. So Heleen has influenced at WITS and in the clinical setting the practice of physiotherapy, and has certainly educated the, you know, I would say the paupers of cardiorespiratory like me to a level where I now appreciate the extensive work that has gone into what she has done. Heleen thanked her family, and I think I would be amiss not to thank you. I have met the family over the years. Professor Van Aswegen, Dad, thank you very much. And Mrs. Van Aswegen. To her brother Hannes, who is all the way in the US, thank you for being there for Heleen, and especially to her sister, Elisma, thank you. I think Heleen has shown what a rounded person she is in her appreciation of family and how we have had the privilege of meeting with you over the years. Thank you for your support. Professor Madi, Professor Ian Jandro, thank you. Thank you for gracing us this evening and for honoring Heleen for this important day in where she is delivering her, or has delivered her inaugural speech. To the heads of department, Professor Nsia and Professor Amos Stewart, thank you for your support of Heleen and all the colleagues and staff in the Department of Physiotherapy within our school. To the hospitals, I know that many of you will know that I'm passionate about ensuring that the link between hospitals and the university becomes stronger than ever. Thank you for your support. It does not go unnoticed. And I think that if there's one area in the School of Therapeutic Sciences is within the Department of Physiotherapy, where we have tried to keep those links alive. So thank you for your support. May it just grow stronger. And to all those who have come tonight, her students, her friends, thank you for coming and thank you for gracing us this evening. I think Heleen has very eloquently outlined the journey that she has taken in the area of cardiorespiratory or cardiopulmonary physiotherapy and the growth that has happened in the last 20 years. And what I'm proud of as head of school, as a colleague and friend, is just to see the contribution that has been made and to give the evidence that is required. She gave us a slice of her journey, and I can assure you that was just a fraction of the 65 articles that she has published. And she illustrated this beautifully by going through the scope of practice, showing the role of physiotherapy. Sorry, I nearly said our role because I'm a physio, so. But I have to always remember I'm head of the school, not of the department. So the role of the physiotherapists and the extent to which physiotherapists work. What physiotherapy should be doing in terms of minimal clinical standards. She has also shown the effectiveness by testing the practice of actual patient care in the different aspects of the alphabetical up to H, A, B, C, D, E, F, G, and H. She has examined elements of some of the treatment-related components, such as the sources of infection in the use of nebulizers, effectiveness of widely used techniques, such as manual hyperinflation, spontaneous breathing, mobilization, exercise, and also looking at the outcome measures, and all this with good outcomes. Importantly, Professor Van Aswegen has worked across the continuum and tested outcomes beyond hospitals into the community. She knows how that warms my heart. And looked at function and health-related quality of life. She has taken her work and translated it into her teaching in the wonderful textbook that she co-authored and has outlined for you. Her passion for evidence-based practice is not matched by many. Personally, I always look for the good in people. So identify people's strengths very quickly. And I am keen to gain from such strengths. One of Prof. Van Aswegen's many strengths in her is her attention to detail, to precision, and quality. Thank you for bringing that to your work. and to us in our school and in the department. I'm personally very grateful for that, because I think if we have our quality master, I think we will stay on the right road. On behalf of the university, the faculty, and the school, I wish you well in your future endeavors. And I can vouch that as long as I'm here, you will have my support. I've just prepared a small contract for you to sign that you are staying at Wits, so thank you very much.
Thank you, Prof. Merswa, and my apologies. I should have apologized upfront for coming late. I didn't realize it would be quicker to walk from the park on campus to Wits than to actually take a car, which, Ian, speaking of, I think the elevation is high enough to get a zip line between the two campuses, which would be much more predictable. So my apologies. So it leaves me now just to thank everyone, both colleagues, students of Prof. Aswegen, and most importantly, family and friends who have graced us with your attendance to really pay homage to award and recognition of Prof. Aswegen's contribution to the therapeutic sciences. So thank you for your attendance. And at this stage, I'd like to invite you to join us for refreshment outside. Thank you very much.